Shraddha is not there.
Yeah, good afternoon everyone. So my study is titled Comparative Outcomes of Primary Congenital Trabeculotomy with Trabeculectomy in Phacomatosis pigmentovascularis versus Sturge-Weber syndrome. So what is Phacomatosis pigmentovascularis or PPV? It's associated with port vein stain and pigmentary nevi, whereas Sturge-Weber syndrome is associated with port vein stain and leptomeningeal angioma. So the basic difference is, though both are phacomatosis associated with port vein stain, leptomeningeal angioma with or without glaucoma, Sturge-Weber syndrome is usually unilateral, whereas phacomatosis pigmentovascularis is usually associated with dermal melanosis additionally, and it is often bilateral. The incidence of glaucoma is 30 to 70% in Sturge-Weber, whereas it has not been studied so far, and only one study suggests that it is 75% in PPV. So this is the surgical video showing after the limbal based conjunctival excision, you can see the extensive vessels which are cauterized, and the Schlemm's canal is identified. 120 degrees trabeculotomy done with Harm's trabeculotome, and then trabeculectomy is continued. The deep ostium is excised, and surgical peripheral iridectomy is done, and the conjunctival closure is done. So experience of combined trabeculotomy with trabeculectomy in Sturge-Weber, it is around 80 to 100% success in our own study, but there are only few case reports or case series published on PPV, and the one from Dr. Mandal et al. Which says that it is around 80% at the end of 14 years. So though both are phacomatosis, the comparative outcomes between PPV and Sturge-Weber has not been studied. So this is the purpose of the study, to compare the outcomes of primary CTT in these children. So this is a retrospective study conducted on patients with early onset glaucoma in Sturge-Weber and Phacomatosis pigmentovascularis who underwent CTT and with a minimal follow-up of 1 year. Diagnosis was primary clinical, and complete success was defined as when the IOP was more than 5 and less than 16 millimeters under general anesthesia and less than 21 in clinic with or without anti-glaucoma medication. Failure was defined as IOP beyond the above said range, IOP range, need for additional surgery, and loss of light perception, RD, and hypotonia. So coming to the results, 48 eyes of 32 children in PPV group and 49 eyes of 49 children in Sturge-Weber group were included. Though the majority of the baseline characteristics were comparable, age at presentation and age at glaucoma surgery, the epilepsy and abnormal MRI findings were higher in the PPV group. So coming to the postoperative outcomes, though the IOP outcomes were similar between the two groups, the need for additional AGM were higher in PPV group when compared to the Sturge-Weber group. So coming to the success, though qualified success was similar between the two groups, around 98% at 1 year and 93% at 5 years, the complete success was better in Sturge-Weber group compared to the Phacomatosis pigmentovascularis group. And the complications also in Sturge-Weber group, majority of the complications were medically managed, especially the choroidal detachment. But in PPV group, complications like hemorrhagic CD, recurrent retinal detachment, phthisis was higher, and the need for repeat glaucoma surgery was also higher in PPV group. And the risk factors for failure of CTT were common, like age at presentation, corneal haze, and then higher cup disc ratio. These were the common risk factors between the two groups. Additionally, presence of anemia and presence of choroidal hemangioma were the additional risk factors in PPV group. So to summarize, CTT, though it's an effective option of managing early onset glaucoma in both the groups, in patients with PPV, it had less favorable outcomes with a greater need of additional interventions as well as greater need of additional AGMs. So it is important to have an individualized care for these patients, that there are distinct challenges posed by Sturge-Weber and Phacomatosis pigmentovascularis, and it necessitates tailored management strategies. Thank you.
So any of your patients had any suprachoroidal hemorrhage and all that while you was doing surgery?
Not intra-op, they had during the post-operative period.
Because sometimes
Dr.
we need
Sonal
to use
Gupta, please come here. Sonal Gupta.
an AC maintainer when we are dealing with these patients. So I think when I saw your video, I didn't see any.
Yeah, so what we have observed is in late onset glaucoma, these complications are higher when compared to the congenital glaucoma in these children. So the onset of complications are lesser in these children.
So,
And in PPV patients, how many AGMs did they require once your surgery did not give the desired result?
The median of 1 to 2, median AGM of 1 and 1 to 2 was interquartile range of 1 and 2.
So the conclusion basically is that with CTT the prognosis is better in Sturge Weber. That's it.
Sturge Weber is better than
Better.
PPV.
So
yes.
that's your conclusion.
Yes,
That's
the success rates are better in Sturge Weber.